module will be on these learning objects to equip all of you to diagnose a case of the diabetes, classification of the diabetes, especially the diabetes in young. What is the initial evaluation of the patient with respect to the metabolic control, and what about the complications presence and other comorbidities. So this is the diagnostic criteria. So you are all of you. These are the 4 values. Out of 1 is sufficient to diagnose the diabetes. 1 out of these 4. What are they? Fasting blood sugar more than 126, postprandial more than 200, random more than 200 plus symptoms, and HbA1c more than 6.5. Now here, Mr. asymptomatic 32-year-old male, asymptomatic 32 years, found to have fasting glucose 138. His father has type 2 diabetes. His BMI is 24. So what is the working diagnosis? What is the working diagnosis? Any one value out of these 4 is diagnostic of diabetes. Fasting more than 126. Diabetic or not? Okay, which diabetic? Why? Good, family history, and also see the BMI. Obese. So obesity, family history, more in favor of type 2 diabetes. So is a diabetic. Undoubtedly is a diabetic because fasting more than 126. Again, diabetes is an RMP diagnosis. For you, for a doctor's diagnosis, diabetes of what? Cori. So fill that query with type 2 diabetes here. So what is your diagnosis? Diabetes type 2. Do you need any other test to confirm the diagnosis? For confirmation, do you need? Usually don't need, but you get the postprandial blood sugar, you get the HbA1c, and also get the other tests to rule out any complications even at the time of the diagnosis itself. So another case, female, 48 years. So you have to respect the age importantly, especially in the women, whether premenopausal or postmenopausal or perimenopausal. Okay, so as long as they are menstruating, their uric acid levels will be good. So they don't get usually the gout. As long as they are menstruating, their vessels are good. They don't get the ischemic heart disease because of the protective effects of the estrogen. In the postmenopausal woman, more chances of vascular events, more chances of hyperuricemia, more chances of osteoarthritis, etc. etc. So she has no family history of the diabetes. BMI how much? Overweight or obese? Good, obese. No family history. She complains of weight loss, polyuria, polydipsia for the last 6 months. Last 6 months, symptomatic. Weight loss, polyuria. What is the random blood sugar? 335. What is your working diagnosis? Good, diabetes. And also obesity. So in a single word, diabesity. Diabesity. Diabesity means diabetes plus obesity. So she is having diabesity, almost a perimenopausal woman. Okay. So what is your diagnosis here? Is it type 2 diabetes or type 1 diabetes? Usually obesity and diabetes means type 2 diabetes. But usually type 2 diabetes is asymptomatic. But here it is symptomatic. She is symptomatic. So type 2 diabetes diagnosed at a later time, keep on continuing the blood sugars. So obviously they will become symptomatic because of what toxicity? Good. What toxicity? Good. What happens her blood lipids? What toxicity? Good. So she might be in glucose toxicity and lipotoxicity to cause symptoms. So my gut feeling is probably type 2 diabetes. But because of the undiagnosed for the last so many months, the sugars keep on gaining, reaching a stage of glucose toxicity. Once she is in glucose toxicity, she will be symptomatic or asymptomatic? Symptomatic. So what is the treatment right now? Insulin for the time being to control your metabolic consequences. Later, shift to OHA, dietary approach, exercise, weight loss, etc. etc. Do you need any other test to confirm the diagnosis? Usually for confirmation, no. But yes, to know the other things, and also you need all other profiles. See, this is the natural history of the diabetes. So again, diabetes is progressive, aggressive, dynamic. So the same thing happens to the disease also. But this is a very important slide. See the reverse. Suppose in the first one, they have the 4 phases of the life. So some of you is in the first one, that is normal glucose tolerance. Some of you are in the pre-diabetic range. Okay, I hope that none of you is in the clinical diagnosis range. Suppose your parents, maybe some of your parents may be in the clinical diagnosis range, and some of your parents or your relatives are in the last stage also, that is complicated diabetes. Am I clear? So what happens in the normal glucose tolerance? Our aim is always keep them the normal glucose tolerance only. So don't push them into pre-diabetic range. So the pre-diabetic range, 2 things will happen. If you don't intervene, they will go into the diabetic range. If you intervene with the diet and exercise, what will happen? They will come back to normoglycemia. And then if they are in the clinical diagnosis of the diabetes, again in the diabetes you have the 2 things to happen. One is, if you don't treat properly, they will get the complications. Suppose if you treat properly, reduce the body weight, and then even a pre-diabetic phase is also possible. That is reversal of the diabetes is also possible. So that is also there. So you have the role in all the 4 phases. Suppose tomorrow you are seeing one family, one male or the female, one wife and husband are the diabetics. So don't stick on to the wife and husbands being the diabetes and not to have the complications. But you also stress upon the children of them, because they are also at risk of getting diabetes. So that means you are going to treat the mother, the father, and also children. Right now they are in the NGT, normal glucose. You have to warn them. Suppose they are obese, so you have to warn them to reduce the body weight. Suppose they are physically inactive, so make them more and physically active, etc. So this is the how. So diabetes means not an individual management. It is a family management. Okay. See, they already I told you the pre-diabetic ranges, okay, and post these one things. Suppose here the postprandial is 129. What is your diagnosis? Fasting is 120, postprandial is 129. What is your diagnosis? Good, pre-diabetes. Again, pre-diabetes in which phase? IGT or IFG? IFG, impaired fasting glucose. This is IGT. So IGT means impaired glucose tolerance. IGT means pre-diabetes. Pre-diabetes of postprandial glycemia. So whenever you see the results, see this. First you see the fasting one. So is it less than 100 or more than 126? More than 126 is a diabetic. Less than 100 is a normal. Here 96, so normal. Okay, leave that. Go to the second value, 186. More than 200, diabetic. Less than 140, normal. 141 to 199 is a pre-diabetic, IGT. You should take at least only 1 second or 2 seconds to diagnose these things. Otherwise, you are all poor. Okay, good. Next, includes the 4 classes, classification. So type 1 diabetes, you all know what will happen to your beta cells? FAT. Insulitis, total antibodies, destruction of the beta cells. There is no insulin production, insulinopenia, insulitis, etc. So this is of 2 things. One is immune mediated and the second one is idiopathic. What you mean by immune mediated? Antibodies. Your GAD65 antibodies, your insulin antibodies, your pancreatic antibodies, your beta cell antibodies. All these antibodies bombarding the beta cells not to function at all, to stop producing the insulin. So obviously the person will get the diabetes. So that is type 1 diabetes. Suppose it is a type 1 diabetes, but the antibodies are negative. So that means that is idiopathic. That is idiopathic. So what is the take home point? Even though if you diagnose the type 1 diabetes, don't expect 100% positive for your GAD65 antibodies. So 95% will be positive. In some cases that may be the negative. So even the negative is also possible in type 1 diabetes because it is of idiopathic subtype. Suppose immune mediated 95%, but 5% idiopathic. So type 2 diabetes. So this is a combination of your insulin resistance and insulin deficiency. Other specific types, monogenic diabetes syndromes. So that is called as MODY. maturity onset diabetes in the young individuals. That is a monogenic. Usually diabetes is polygenic. Multiple factors are there. But the single gene defect, it is monogenic. So that is called MODY. That is maturity onset diabetes in the young individuals. And this is with exocrine pancreas. So tropical pancreatitis. Your amylase will increase, your lipase will increase, and also your sugar also will increase. So what it means? It means pancreatic defect both ways. One way, exocrine. Another way, endocrine. So exocrine dysfunction leading to abdominal pain, steatorrhea, pain in the epigastric region, radiating in the back, history of pancreatitis, history of the gallstone disease, etc. So that is acute pancreatitis or chronic pancreatitis. And now the sugars are also going up. That means both exocrine dysfunction and endocrine dysfunction. So that is called pancreatic diabetes. Type 3C. That is type 3C, pancreatic diabetes, pancreatogenic diabetes. And then drug or chemical induced diabetes. What drugs will cause diabetes? Steroids, diuretics, beta blockers, immunosuppressive drugs. Okay, so these are the common drugs which can cause the diabetes. Your diuretics, beta blockers, steroids, immunosuppressive drugs. Then the gestational diabetes. Now it is gaining up. Earlier, gestational diabetes means very few cases. Maybe one case or two cases in a month. Now I am seeing at least 2 cases a day of this GDM. Almost all the pregnancies right now, they are mostly the GDMs only. Maybe because of obesity, childhood obesity, maybe because of the late marriages, maybe because of the first pregnancy after 30 years of the age group. Book says more than the 25 years, most lot of the people are professionals. By the time they are married and getting the pregnancy, so obviously 30, around 30. So it's again a big risk factor to get the gestational diabetes. And strong family history, physical inactivity. So these are all the risk factors for the gestational diabetes. So the different types of the diabetes seen in the youth, that means less than the 20 years of the age group. 20 years of the age group, you are seeing a diabetes. So one of these causes. Not all because of the type 1 diabetes. I say type 1 diabetes occurs less than 20 years of the age group. Not all 100%. Suppose 18-year-old boy comes to you with a diabetes. What are the reasons? Could be type 1, could be early onset of the type 2 diabetes, could be MODY, could be pancreatic diabetes, both exocrine dysfunction and endocrine dysfunction. So the type 1, MODY, type 2 early onset, and fibrocalculous pancreatic diabetes, that is a pancreatogenic diabetes, may be drug induced, secondary to the endocrinopathies, like your hypothyroidism, acromegaly, Cushing's. So they also may cause the diabetes. That is endocrine diabetes is also common in young individuals. And if the happens to be a female, so that could be a gestational diabetes also. So these are the different types of the diabetes you often see in the young individuals. So don't stick on to the only type 1 and the type 2. Other types are also common in a young individuals. Am I clear? Good. So the type 1 diabetes, the patients are dependent on the exogenous insulin injections for survival and health. So the insulin is needed for survival is the type 1 diabetes. Insulin is needed not for the survival in type 2 diabetes, but to prevent the complications or to prolong the life. Epidemiology, 5 to 10% of individuals with diabetes have the type 1 diabetes. Not the 5 to 10%, I think maybe 2 to 3%, maximum 5% of our people are having the type 1 diabetes. Geographical variation is observed. Yes, it is very common in cold climate countries like Finland, Iceland, Denmark. So very high number of the type 1 diabetes in them. All the teachers are trained to identify the hypoglycemia and hyperglycemia, and there will be one freeze, fill of the insulins. Though this insulin is for Seta, this insulin is for Geta, this insulin for Rama, this insulin for Krishna, this insulin for Sai, this insulin is for Christopher, etc. and etc. All the freeze is filled with insulins for the at the level of LKG, UKG, first standard, second standard. Where? Not in India, but in cold countries like Iceland, Denmark, etc. and etc. So this is very, very common there, type 1 diabetes. Fortunately, it is not that common in India, but right now we are seeing more and more type 1 diabetes also. So that is another story. Onset usual in the childhood and adolescence, but can occur yet. So that is the beauty of the medicine. So that is the beauty of the, if you diagnose the diabetes at the 50 or 60, you will have a lot of the professional satisfaction. So money comes, money goes. You should enjoy the profession. You should develop the passion for the subject. Okay, so then you will be very, very, very happy. Okay, so the type 1 diabetes occur at any age group. What are the symptoms? Are they symptomatic or not? Type 1 diabetes. All are symptomatic. Very symptomatic. What are the symptoms you get it? All the 3 P's and also weight loss. What weight loss? Intentional or unintentional? Unintentional weight loss. So just think of type 1 diabetes in them. So what about the early onset of the type 2 diabetes? So suspect the type 2 diabetes in any young patient who has strong family history of the diabetes. Signs of insulin resistance like obesity, acanthosis nigricans, skin tags, fail to good beta cell reserve as measured by the C-peptide. So if you are in a doubt, young fellow, it could be diabetes, type 2 diabetes, etc. So you suspect type 2 diabetes, and then how to confirm it? Get the C-peptide. So what happens in the C-peptide? Low or high? High in type 2 diabetes. What about the C-peptide level? Sorry, GAD65 antibodies? Negative. So you are suspecting type 2 diabetes. You confirm the type 2 diabetes also. So on your case sheet, you write it as type 2 diabetes, early onset, red ink, underline it, and then ask the patient whenever you reach to any doctor, tell them that even though you are 14 year, even though you are 12 year, even though you are 15 year, your diabetes is type 2 diabetes. So monogenic diabetes. So the diagnostic criteria, Tattersall and Fazans. Okay, age less than 25 years at the onset. Autosomal dominant transmission of the diabetes, 3 generations. That is a very, very important clinical point. MODY. So getting the diabetes, young age group in 3 generations. So undoubtedly it is a monogenic diabetes. Monogenic diabetes. Absence of ketosis at any time. So do you need insulin? No. Because no ketosis. In type 1 diabetes, why you are giving insulin? If you don't give insulin, ketosis. Ketosis is life-threatening. No ketosis, no insulin. So in MODY, do you prescribe insulin or not? Not needed. So you see the beauty of your diagnosis. Young individual, a diabetic, you diagnose it as a MODY and you are not prescribing insulin. So that is the beauty of diagnosing MODY. So you are in a doubt. So to know whether it is a monogenic diabetes or not, you have to see the gene sequence. So for that you have to send the blood to the higher centers, costing maybe 6,000 to the 8,000. Then they will give the MODY 1 or MODY 2, MODY 3 or no MODY, etc. You will get the report. Accordingly, you can treat them. So these are the clinical features. What are the differences? The MODY and the type 2 diabetes. MODY, they are non-obese, whereas type 2 diabetes, they are overweight or the obese. In MODY, you don't have the acanthosis nigricans, whereas type 2 diabetes, you have the acanthosis nigricans or skin tags. Here the MODY, you have the 3 generations. In the type 2 diabetes, maybe the strong family history, either a parent, either a mother or the father. Only insulin is secretory defect in the MODY, whereas here defect in insulin secretion, also the insulin resistance is the type 2 diabetes. Here seen in all the patients, monogenic, usually in patients with the high prevalence of the type 2 diabetes, like in India, etc., etc., responds better to the sulfonylureas, MODY. So young individual, diabetic, you are diagnosing as the MODY, you don't have, you need not prescribe the insulin, you can use the sulfonylurea. There, diet, exercise, metformin, SGLT inhibitors, etc., etc. Now MODY and the type 1 diabetes. In type 1 diabetes, family history usually negative. Here the 3 generations. Here C-peptide, good. There, very low. Pancreatic autoantibodies are negative here. They are the positive here. Here the response to the sulfonylureas. There, no drug except insulin. So, fibrotic pancreas. So this is a type 3C. Patient should be from a tropical country like India. So we are seeing a lot of the pancreatic diabetes in our area, very common in Kerala and also in Pondicherry and also in Tamil Nadu and also in Kakinada, also in Andhra Pradesh. So young individuals, lean individuals with history of pancreatitis or recurrent abdominal pains, etc. And then if you take an X-ray, you will have a calcifications in the pancreatic ducts. Okay, so that your diagnosis is fibrocalculus pancreatic diabetes. Abnormal pancreatic morphology in the ultrasound abdomen, pancreatic atrophy or pancreatic calcifications or head of the pancreas is damaged, etc. Such reports you can see it. Recurrent abdominal pain, steatorrhea, abdominal pancreatic function tests like amylase and lipase. See here the calculi. History of oily stools and recurrent abdominal pain, severe diabetes. Most commonly found in Kerala, Tamil Nadu, Andhra Pradesh also. Etiology is not known, exact etiology. Significant increased risk of pancreatic carcinoma. This is the very important. So the risk of pancreatic carcinoma is very high with these individuals because of the both exocrine as well as the endocrine dysfunction leads to the pancreatic carcinoma. Slowly evolving, this is the LADA, type 1.5. Okay, positive for at least one of the autoantibodies, age at onset more than 30 years, free from insulin treatment for the first 6 months after the diagnosis. So in the initial days, they almost behave like the type 2 diabetes. So you are prescribing the OHS, you are telling the diet and exercise. In the next visit, the blood sugars are very high. Again, you are changing the OHS or increasing the strength of the OHS. In the next visit, again the blood sugars are very high. That means they are presenting like the type 2 diabetes without any symptoms, etc. But slowly they are evolving into type 1 diabetes. Now slowly they are become the symptomatic, they are the losing weight, etc. Within 6 months or the 1 year, then you should revise the diagnosis as earlier type 2, now type 1. So type 1.5. So the diagnosis is LADA. So what is the treatment for LADA? Initial days, as they behave like the type 2 diabetes, OHA, and the later stage, insulin. Good. So this case, 9-year-old boy presents to you with the complaints of polyuria, polydipsia, polyphagia, tiredness, abdominal pain, and burning micturition. Fasting 20, postprandial 34, A1C 10. So what is the working diagnosis here? Good. Family history. So don't think that all type 1 diabetes in the youth. It could be type 2 diabetes also. So again, not only in the parents, 3 generations. Okay. And then history of abdominal pain, recurrent abdominal pain, steatorrhea, etc. to rule out your FCPD also. Okay. And then see the young authors negligence or skin tags, etc. to know whether there is any insulin resistance markers are the rate to rule out any early onset of the type 2 diabetes. So it is not known to have the diabetes previously, same, no family history of the diabetes. What is your diagnosis at this stage? What will you look for in the examination? See the BMI, 12.5, very lean. Okay, no markers of the insulin resistance. Dehydration is present. So more in favor of type 1 diabetes. More in favor of type 1 diabetes. So what investigations will you ask? So dehydration, urethritis. So go for the ketone bodies, etc. Bodies positive. Next day she will end up with DKA. So serum beta hydroxybutyrate is elevated. That is our ketone bodies. You have the 3 ketone bodies: beta carboxyhydrate and then acetone and acetate. Okay, beta hydroxybutyrate, acetone and acetate. Lipid profile, high triglycerides. Why high triglycerides? Neoglucogenesis. So the lipids are also converted to the glucose. While converting to the glucose, causing more and more free fatty acids. And then ketonemia, ketosis. C-peptide, low. Stimulated C-peptide, again low. What about the GAD antibodies? Normal is 8, less than 8. She is having 58. So C-peptide low, GAD anti-65 antibodies positive, ketosis is positive, 9 years old, no strong family history. So what else you require? So pakka your diagnosis is? In India, type 1 diabetes. In America? In America? Good. In UAE? What is the management? Suppose you went to Australia, what is the management? Lifelong? Yes. Ante. So that's how you have to come to a conclusion. Am I clear? So you have to see 360 degrees. So management. So right now she is having urethritis. So take care of that urethritis. Right now she is having ketone bodies positivity. So give more fluids, water fluids, more normal saline, more insulin, and also antibiotic. Which antibiotic? UTA specific antibiotics. What are the drugs? Good. You can use the nitrofurantoin, you can use the quinolines, especially norfloxacin, etc. So that's how you have to treat them. So don't give the monosef as if she is deficient of ceftriaxone. You're all for, So first drug for any antibody start with the monosef as if they are deficient of ceftriaxone. Okay, so give UTA specific antibiotics here, and if possible get the urine culture also, whether it's E. coli or whether Klebsiella or etc., because ascending UTA will cause pyelonephritis. Pyelonephritis will damage the kidneys, and then you may post it for nephrectomy also sometimes. So don't underestimate urinary tract infections in a type 1 diabetic individuals. So be aggressive in treating the urinary tract infections in type 1 diabetes, because they're ascending UTA, then go to the pyelonephritis, and then if you send the kidney is very much enlarged and filled with a lot of the pus, and you see the IVP, and the dye will not enter into the other kidney, and the other kidney is almost dead. And then if you show to the urologist, and he says that only nephrectomy is the answer for that. So unnecessarily we have to sacrifice important organ in the body for pyelonephritis, acute pyelonephritis. So that is very, very important. So this is another case, a 12-year-old girl presents to the OPD with a diabetes of 6 months duration. 12 years, 6 months history of the diabetes. She has been diagnosed with type 1 diabetes and initiated the insulin based on the age of the onset. So that's what the pediatricians usually do it. All the diabetes in that age group, they thought that it is type 1 diabetes and started on insulin therapy. Glucose has always been under poor control. She doesn't have any symptoms attributable to the diabetes. She is asymptomatic diabetes. Fasting 190 T6 200, PPG 300 plus, A1C nearly 10%. She has a strong family history of the diabetes. So what is the working diagnosis? You should suspect early onset type 2 diabetes. What are the points here? Family history, asymptomatic. See the history. See the case history. Weight. What is the BMI? 27. Is she normal weight or overweight? Obese. A1C 9.8. Abdominal X-ray normal. Eye examination normal. On examination, acanthosis nigricans is present. Marker of insulin resistance. So what is your diagnosis? So C-peptide, you got it. See, the fasting is one. Stimulated C-peptide is elevated. That means you are having more insulin. What are the GAD antibodies? Less than 8 is the normal. 4.2. Earlier case 25. So here the GAD negative, C-peptide is good, strong family history, acanthosis nigricans, age is just 12 years, and diabetes. So your diagnosis is type 2 diabetes. So stop using insulin. Diabetes, no insulin at all. How pleasant it is. So that is the beauty of our diagnosis, diagnosing the type 2 diabetes. Okay. Now what is the management? Lifestyle, acanthosis nigricans, obesity, cut down. Sorry, what OHS you prescribe? Metformin. Another case, 15-year-old girl presents to the OPD with the complaints of recurrent boils on her hair, on her back. So skin and subcutaneous infections because of hyperglycemia. Fasting 200, postprandial 300 plus, HbA1c nearly 10%. Detected to have the diabetes at the age of 13 years. So last 2 years she is on drug therapy and evaluating for the urinary tract infection. She had a strong family history of the diabetes. So you should take that history. Mother, maternal grandmother, maternal aunts, sister. So what is your diagnosis? Good, excellent. See, what is do you prescribe insulin? No insulin for Modi. Only sulfonylureas. See again the beauty of the diagnosing the Modi. So age 15 years. Otherwise the diagnosis type 1, how long insulin? Lifelong insulin. Now no insulin at all, just sulfonylureas. See the history. BMI is 20, case studies. C peptides are normal. Impression, fairly good pancreatic beta cell reserve. The diagnosis is the Modi. Another case. 20-year-old male presents to you with a diabetes of 2 years duration. Complaints of recurrent abdominal pain and passing oily stools on and off. No family history of the diabetes. No smoking, no alcohol. On oral antibiotic drugs since diagnosis, but control has been poor. Fasting 200 plus, postprandial nearly 400, HbA1c 10. How will you proceed further? So analyze your pancreatitis. So amylase, lipase, X-ray of the abdomen to know the pancreatic calculi, ultrasound abdomen or CT abdomen for the pancreas, etc. And rule out pancreatic diabetes here. History of recurrent abdominal pain and passing greasy stools. What investigations will clinch the diagnosis? See the X-ray. So just with your brain and one X-ray, you are changing the diagnosis. So he was started on the insulin because very high blood sugars. He is put on the 2000 calorie diet because he is very low weight, body weight. So more calorie diet, more of the protein, etc. And now during the next visit, the fasting come down to normal, postprandial normal, HbA1c from 10% to 7%. Patient continues to do well on the follow-up. So finally, see the 4 cases. This is the best slide of today's talk. See all the 4 cases. Age around 10 years, maybe 9 years, 12 years, 15 years or 20 years. Okay, what are the fasting blood sugar? All are around 200. What are the postprandial? All around 300. What about the HbA1c? All around 10%. So fasting PP and HbA1c almost all the time. The diagnoses are totally different. One is type 1 diabetes, needs lifelong insulin. Another one is type 2 diabetes, weight reduction and then the physiotherapy, etc. And another one is monogenic diabetes, only sulfuridas. And then pancreatogenic diabetes, where you have to give the pancreatic extractions also, like your supplementation of the pancreatic juices, like your cream, 10,000, 25,000, etc. You have to give the pancreatic enzyme preparations also in those people with the pancreatic diabetes along with your insulin or the OHS. So diabetes in youth is heterogeneous and needs the detailed evaluation. All these years you think that less than the 20 years mostly type 1 diabetes and keep on using the insulin. From tomorrow onwards your mindset has to be changed that it could be one of these 4 and act accordingly. So how the initial evaluation of the patient with the diabetes? So type 2 diabetes is the most common, prevalence, etc. Ask for the symptoms of the diabetes. Again I am telling you, what is the commonest symptom of the type 2 diabetes? No symptom at all, asymptomatic. But some people will have a frequent urination, excessive thirst, excessive hunger, weight loss. They are all because of the glucose toxicity. Delayed healing of the wounds. Sometimes the surgeon will diagnose the diabetes because of the uncontrolled foot ulcers. So they go to the surgeon for the dressing and etc. And then the surgeon asks this fellow, what is the duration of this ulcer? 2 months, 3 months. Are you a diabetic? No. Get the blood sugar done, 400. Okay. So delayed healing of the wounds, very important. Tiredness, itching especially in the genital area. That is a very common presentation in our Indian population. Balanitis. In the same way, vulvovaginitis. So these are the very common presentations in our setup to diagnose the diabetes. Anyone is having the history of the balanitis and vulvovaginitis, so one should screen for the diabetes, and obviously the sugars will be high. And tingling and the numbness, especially in the feet, and then visual disturbances because of your retinopathy. And some people they may present with ED. What is ED? Erectile dysfunction. What is other ED in diabetes? Endothelial dysfunction. What is? Which ED is more common? Endothelial dysfunction is very common. Okay. So erectile dysfunction is very common in diabetic individuals. In the same way, endothelial dysfunction is also very common. So endothelial dysfunction is because of your atherosclerosis. Is there erectile dysfunction? Is because of your neuropathy at the pudendal nerves and etc. This is also very common presentation. So some of the individuals they present with ED to us, and we have to diagnose the diabetes and then treat accordingly. So we have very good drugs to treat the ED right now. Both the EDs. Endothelial dysfunction with your statins, your proper control of the diabetes, proper control of the hypertension, and cessation of the smoking, etc. In the same for the ED, we have the Viagra and etc. Other drugs also there. They are the very, very good game changers in the management of the diabetes. And again, in both the EDs, the base rule is control blood sugars very effectively. So in a diabetic individual, whatever the presentation he might be, but our goal is keep the blood sugars under good control. So then treat accordingly. Am I clear? So more than 60% of the patients do not have any symptoms. My percentage is maybe more than 80% or maybe more than 90% also. So there are all the medical history, you have to take it. History of hospitalization. So all the people should ask the history of the hospital. Suppose type 1 diabetes. Do they require more hospitalizations or not? Yes. Why? Ketosis. So this occurs in the young individuals, students. So mothers are very busy. The father is very busy. So they may skip the insulin injections. After skipping 3 or 4 insulin injections, they develop ketosis. So on holiday, so they go to their in-laws' house or they go to the grandparents' house and they may skip the insulin and again they present with ketosis. So frequent hospitalizations, more in case of type 1 diabetes. Type 1 diabetes. Ask the symptoms, suggest for the complications. All the complications you should ask. So symptoms of your CVA, your TIA, etc. and the symptoms of the heart failure, coronary artery disease, symptoms of the peripheral vascular disease, that is means intermittent claudication. So he may be able to walk for a few distance and again you have to take the rest. Again walking for the some other distance, that is called intermittent claudication, more in favor of peripheral vascular disease. Yes, peripheral vascular disease. Okay. So here one case. Male 46 years, newly diagnosed the type 2 diabetes. First visit to the hospital. Height is 168, weight is 74 kgs. BMI 26. BP 140 by 80 in the supine posture, 150 by 80 in the erect posture. So what is the working diagnosis? Isolated systolic hypertension, where the systolic blood pressure is 140 or more than 140 with a normal diastolic blood pressure. Okay. Now what is isolated diastolic hypertension? Diastolic more than 90 with a normal systolic. That is isolated diastolic hypertension. So what are the common causes of IS? So what is the common cause of isolated systolic hypertension? Elderly, old age. What is the common cause of isolated diastolic hypertension? Hypothyroidism. So for all your cases of hypothyroidism, you have to check the blood pressure very carefully. Not only the systolic, you have to give more importance to the diastolic. That is the most important take-home point from today's talk. So most of the times now you check the systolic. Systolic is 130. You assume that diastolic is also normal in all the hypothyroid individuals. If you check the blood pressure very effectively, and then the diastolic will be 100. Systolic is 130. So 130 by 100 is isolated diastolic hypertension. Very common in hypothyroidism. What happens in hyperthyroidism, Graves' disease? Reverse. Systolic will be 160, 170, 180. The diastolic will be normal. That is isolated systolic hypertension. Very wide pulse pressure. Okay. What happens in gas anemia? Again, isolated systolic hypertension. What happens in pregnancy? Again, isolated systolic hypertension. So in all conditions, hyperdynamic circulatory conditions like anemia, like beriberi, pregnancy, hypothyroidism. So these are all hyperthyroidism. You will have isolated systolic hypertension. What additional signs should you routinely look for in patients with the diabetes? What are the signs you look for? Velvety appearance of the nape of the neck, skin tags, abdominal adiposity. Okay, thyroid. Please examine the thyroid in all the diabetic individuals. Just see the neck. Some people will have the goiters. Some people will have the simple goiter. Some people will have the multinodular goiter. Some people will have the toxic nodular goiter. and see the eyes immediately after the seeing the neck, suspecting the thyroidomegaly, see the for an exophthalmos etc. So to rule out hyperthyroidism, and see the arms very sweaty, so more in favor of hyperthyroidism. See the pulse, tachycardia, so more in favor of hyperthyroidism. So without any investigations, you can come to a reasonable diagnosis that this fellow is a diabetic, not only diabetic but also hyperthyroid. Okay, so having the antibodies for both the thyroid as well as the pancreas. So the physical examination, so top to the bottom. Okay, some people will have alopecia, some people will have the psoriasis, some people will have the acanthosis nigricans not on the nape of the neck, some people will have the black patches, thickness, pigmentation. So that is also feature of acanthosis nigricans. Okay, the face, see the anemia, see the jaundice, etc. So these are all very, very important. Neck, I already told you the thyroid. Some people will have the subcutaneous nodes. So that means your nodular tuberculosis. Very common in the diabetic individuals. Okay, and then some people will have the CSOM, pus oozing from the ear cavities in uncontrolled diabetic individuals. Some people will have post-COVID diabetes, uncontrolled, will have mucormycosis. Okay, so these are all the things from top to the bottom. You have to see that examination. Comprehensive foot examination. So the foot is very, very important in all the diabetic individuals. Of course, you are giving a lot of importance to your face. All the diabetics should give equal importance to the foot also. Sometimes you have to give more importance to the foot rather than the face, because the foot is at risk of getting the ulcers, then the amputation, below knee amputation, above knee amputation, total amputation, and all the amputated fellows will die much early because of the vascular insufficiency. Okay, so we have to give a lot of importance to the foot, both inspection, palpation, auscultation of your dorsalis pedis vessels and posterior tibial, and they have to see the sole of the foot, and they have to see the interdigital areas for any fungal infections, etc. Corns. Okay, so these are the important areas to be looked for in all the diabetic individuals. And of course, you have the tuning fork, so ankle reflexes, knee reflexes, etc. And if you have the Doppler ankle brachial index to rule out the peripheral vascular disease. So normal is less than the 0.9. If it is less than the 0.4, more in favor of the amputation. See the ankle jerks, see the vibration sensation. So this is a monofilament test. This is the 10 grams. Siemens Winston's 10 grams monofilament test. Lab investigations, your profile you have to done it. So the diabetic profile, renal profile, liver profile. Okay, 3 months average. Your again urine protein, your C-peptide levels, GAD65 antibodies if needed. Thyroid profile, especially in the women with the diabetes. Okay, so these are all the profiles you need it to, you know the ingredients of your metabolic syndrome also. So for that also you need a lipid profile. Okay, so these are all very, very important. So the different methods, oxidation reduction, exokinase. So right now we are using the exokinase method. Enzymatic methods are more preferable right now. Capillary blood sugar, venous blood sugar, arterial blood sugar. So which blood sugar, which blood will have more sugar? Arteries or the veins or the capillaries? Arteries, obviously. After the arteries, veins or capillaries? Capillaries. Least is the veins. So you have the no glucometer, and also you have the lab. Which one is showing more blood sugars? Good, your glucometer. Because we are getting the capillary. Capillary is containing more oxygenated blood when compared to the venous. Venous 100% deoxygenated. Whereas capillaries, some amount deoxygenated, some amount oxygenated. So that means it contains more blood sugar when compared to the venous blood sugars. Am I clear? Urine glucose. Any role of urine glucose nowadays? No, obsolete. So still no, a lot of the people, they give the blood sugar and also the urine sugar. So don't encourage urine sugar test in any diabetic individuals. So all the medications, what are all the changes you are going to do it on behalf of your blood sugars only, not the urine sugars. Am I clear? Okay. But urine examination is important, not for the glucose. Urine for protein, urine for microalbuminuria, urine for pus cells, urine for ketone bodies, urine for urobilinogen. Okay, the patient is also having the jaundice, etc., but not for the glucose. So what is the diagnosis here? Sugars are, blood sugars are normal or abnormal? Normal. What about the urine sugar? Increased. So what is the term you given that? Glucosuria. Glucosuria. Do you treat them? Do you give any OHS here? Are they diabetics? No. Diabetes only because of your hyperglycemia in the blood sugars. Even though they are having glucosuria, don't consider them as a diabetic. Okay. So is this possible? Yes, possible in some cases. When the renal handling is defective. Diabetes. So even in the high blood sugars, you can have sugar nil. Okay. So this slide. Even with the normal blood sugars, you can have the glucosuria. So this is the most important take home point. From tomorrow onwards, urine sugar has no role in the management of the diabetes. Some people, even with the normal blood sugars, can have urine glucose 2+ or 3+. On the other hand, when the more the blood sugars also will have a nil urine sugar. So glycosylated hemoglobin, HbA1c, is it a good test or not? Very good. It tells you the average of the previous 3 months, 90 days. Why 3 months? Lifespan of the RBC. So that shows the glycosylation of your hemoglobin. So that is HbA1c. So very important test. So I often see my patients now only once in 3 months. Get the HbA1c done, and according to the HbA1c, I change the medications. So all the long-term complications are dependent on HbA1c rather than your fasting and the postprandial blood sugars. Fasting and postprandial are modifiable, but not the HbA1c. Okay, so that is very important. So don't give lot of importance to the fasting and PP. You have to give more importance to the HbA1c because this is the long-term control of the diabetes. All the diabetes complications are because of your long-term failure. Why you are treating an asymptomatic individual, Ramjan? Why you are treating an asymptomatic individual? Diabetes asymptomatic. Why you are treating asymptomatic? To prevent complications. What are those complications? Life-threatening complications. So that is the reason you have to see HbA1c at a lower level to avoid the long-term complications. This is the very important. But at the same time, you have the few fallacies values. Suppose one fellow, Seta is my patient, her hemoglobin is 7 grams. So how can you correlate with your HbA1c? Hemoglobin is 7 grams. So she is anemic. Okay. So when the HbA1c is 7, what will happen to your HbA1c? Good. Increased. Okay. So actual HbA1c is about 6.5, but appears to be HbA1c 8. Falsely increased because of the low hemoglobin. Okay. On the other hand, blood transfused, or hemoglobinopathies. Okay. So falsely low. So these are the things are there. So that is also very common. Clinical value. The test results are not affected by time of the day. At any given time you can have it, the HbA1c. Meal intake, no role. Before lunch or before dinner or after lunch, exercise or before exercise, after exercise, the same. Just administer diabetic drugs. They have taken the one tablet, doesn't change the HbA1c on that particular time. Emotional stress, no role. and patient cooperation, whether the patient is cooperative or not cooperative, the values are the same. But all these, the fasting and PP will change. Time of the day, immediate postprandial, high blood sugars, and late, maybe the less blood sugars. Meal intake, when you take more carbohydrate, more sugar, more sweets, obviously the blood sugars will go up, and more protein diet, obviously the blood sugar may come down. Exercise, post-exercise, your blood sugars will come down. Pre-exercise, your blood sugars will be high. Just administer diabetic drug. Suppose you take the sulfurias, so immediately they start acting. Suppose you have taken the insulin, so immediately it acts and the blood sugars will come down. Emotional stress, so the blood sugars will go up because of the cortisol release and etc. Patient cooperation, when the patient is not cooperative and he will be agitated, then obviously the blood sugars will go up. So all these things will change your fasting and the postprandial blood sugar, but not HbA1c. So HbA1c is an index of the glycemic control over the preceding 3 to 4 months. Clinical value is very high. These are the methods. Ion exchange, HPLC. Out of them, HPLC is the most accurate or standard ways of getting. So that gives the test of only HbA1c only. Okay. So this is very most accurate one. Most of the labs, they don't have that machine. So they calculate according to your fasting and the PP and the average. So they give you the HbA1c. So at least once in a year, you get the HbA1c. If any of your family member is having a diabetes, at least once in a year or once in 2 years, get the blood sugar done with that machine, HbA1c method. Okay? Very few places, very few centers will have that HbA1c method. See, unoperated low, high. See the low, hemolysis, hemoglobinopathies, recent blood transfusion, acute blood loss, etc. High, iron deficiency, B12 deficiency, alcoholism, uremia, etc. So drugs affecting targets. American Diabetic Association less than 7. So what is our people? What is your aim? What is your target of HbA1c? Good, good. Make them normal. Why pre-diabetic? Why early diabetic? Why mild diabetic? Those 7, 6. My target is 5.7. Make them the normal. But very, very difficult. Very, very difficult. What is the average HbA1c of the Indian population? Good. Good. Very good. Most of our Indians are having the average HbA1c of 9. That is the reason all the super specialists are very, very happy in the Indian population. Cardiologists, neurologists, nephrologists, general surgeons, all are very, very busy because of the average HbA1c of our Indian population. If you keep the A1c at 6.5 or less than 6.5 or 5.7, what will happen to their complications? Then what about our cardiologists and neurologists? So that is our thing. So what is our target? 5.7, most of our individuals. So suppose if the person is elderly. In elderly individuals, don't aim for 5.7 or the 6. Don't invite hypoglycemia. Okay. So normal values in the non-diabetic population are not well defined, etc. For diagnosis of the diabetes. Earlier, HbA was not included as the diagnosis of the diabetes. Only 3 values: fasting, postprandial, random. But later, HbA was also included as the 4th criteria for the diagnosis of the diabetes. C-peptide assay, I already told you. So C, the red one. Always a close friend of the insulin. So one C-peptide, one insulin levels. So interpretation of the results, significance, investigations, albuminuria, get it done. Estimation of the albuminuria, A1, A2, A3. This is the very important. So what is the normal value of microalbuminuria? Normal value of the protein, urine protein should be less than 30. That is a normal. 30 to 300, microalbuminuria. More than 300, macroalbuminuria or proteinuria. More than 3.5, marked proteinuria or excessive proteinuria, more in favor of nephrotic syndrome. So these values you should remember. Urinary albumin creatinine ratio or microalbuminuria level, less than 30 is the normal, 30 to 300 is microalbuminuria, 300 to 500 is macroalbuminuria, more than 500 is proteinuria, more than 3.5 is marked proteinuria or massive proteinuria. Okay. So these are the values. So this is a very important slide, that heat map. Heat map. On one side, albuminuria levels, microalbuminuria levels. On the other hand, your creatine level, and creatine you will get the GFR. Okay. From tomorrow onwards in the smartphones, your smartphones, you make the GFR. So if you add three values, one is the age of the individual, gender of the individual, and creatine levels. So introduce that app, GFR app. So age, gender, and creatinine levels. You will get the GFR. So according to the GFR, divide the stages into 5 stages. Stage 1, stage 2, stage 3, stage 4, and 5. And stage 3 is again divided into A and B. Okay, 45 to 60 and 30 to 45. Screening for the diabetic retinopathy, all the people should be screened. Type 1 diabetes, when you are going to screen, type 1 diabetes. So type 1 diabetes is an aggressive disease. It is an acute disease. It is a virgin disease. So check the complications after 5 years only. Whereas type 2 diabetes, 50% of the people are metabolic syndrome at the time of the diagnosis itself. Very good answer. See, this is our biothesometer. So ankle brachial index, normal I already told you, less than 0.9, less than 0.4, very severe, needs an amputation. So continuous glucose monitoring. So in some individuals like ITDM, type 1 diabetes, or brittle diabetes, or gestational diabetes, or pre-gestational diabetes, are posted for renal transplantation, are posted for CABG, okay, are posted for the some major surgery. So definitely they need continuous glucose monitoring for the proper control of the blood sugars. So in such individuals, we order the continuous glucose monitoring, and accordingly we see that. Here you know the one point, TIR. What is TIR? Time in range. Time above range, time below range. So in 24 hours you get the blood sugars done. So how many times the time in range? Time in range means your targets. Time above range means the fasting more than 126, postprandial more than 200. Time below range means, so fasting 40, 50, or postprandial maybe 60 or 70, like that. So what happens in uncontrolled diabetic individuals? Time in range is maintained or not? Not maintained. So you have to give the prescriptions to maintain time in range. So that is the beauty of your continuous glucose monitoring values. So this is the patch costing about 5,000 rupees. So immediately you can get the blood sugar done. Okay. So these are the comparisons. See, this is the, so the blood sugars should be like that only, not like very peaks and then low. So that is called as GV. What is GV? Glycemic, good, glycemic variability. So glycemic variability, is it good or bad? Not good. What is the answer? Is it good or bad? Not good. So that is glycemic variability. So keep the blood sugars time in range, not to have more glycemic variability. Earlier, the management diabetes means triad. Control the triad. Triad means fasting, PP, A1C. So that is your glycemic triad. Now the concept is glycemic pentad. Pentad means quality of the life, not the triad. So keep the blood sugar, fasting blood sugar under control, under target, postprandial under target, HbA1c under target, and glycemic variability, no glycemic variability, time in range. And then the last and the most important is quality of the life. Quality of the life. Quality of the life. This is also very, that is our motto. Right now, I always feel that my patient should have a normal fasting, normal postprandial, normal HbA1c, no glycemic variability with good quality of the life. This is also very important. So this is all. See the first picture and the second picture. Which one is bad? So first one is time in range. The second one is very fluctuations. See, very so fluctuated. Okay. So these are all the things, man. This is correct. Again, a very important slide for today's talk. First visit. So don't be happy with only fasting and PP from tomorrow onwards. What are all the investigations you've done? You get all these investigations done. And after 3 months, see the HbA1c, fasting PP and HbA1c. After 6 months, if the lipid profiles are abnormal, get the lipid profiles also. What are all the investigations abnormal in the first visit? You get it done after the 6 months also. And every year, annually, repeat all these investigations. So this is the most, follow-up is very important, not to have the complications. So usually what happens for our diabetic individuals, once in a blue moon, they get all the investigations. So treat the diabetes with any amount of the investigations or any amount of the good drugs. That is not costly. But what is that costly is treatment of the complications is very costly.